So we'll be going live shortly. Going live.
Welcome everybody to this special webinar on World Health Day. World Health Day is the birthday of the World Health Organization, 77 years old today. And importantly, the theme for today and for the year ahead is healthy beginnings and hopeful futures. And we're here together on this special webinar to look at hope for newborn survival and newborn survival across Africa. And if we look at that situation, I'm so honored to be here as your host, standing, yes, as someone who's worked on better measurement of maternal, newborn and stillbirths, but particularly as someone who could have been a newborn death in northern Uganda. I won't tell you how many years ago, but it's not the full 77 years of WHO. We're really delighted to have all of you here and to have a fantastic panel. And we ask that you introduce yourself in the chat so we know that who is here and so that we can link to go faster together. And we want to start by reflecting on where we are. So just today, new numbers have come out for maternal mortality around the world, and progress is being made. Maternal deaths have dropped to 260,000 a year, so a reduction of about 10% in the numbers since the last time the UN put out these estimates, but not fast enough. And then if we look at stillbirths, this new report came out just about 10 days ago. So babies dying after the 28th week of pregnancy, so the last trimester, at least 1.9 million around the world. And at the same time, a report was released on neonatal deaths and child deaths. Shockingly, still 2.3 million neonatal deaths, flatlining for the last 3 years, and around 2.5 million deaths of children after the first month and before their 5th birthday. So together, this is 7 million deaths, particularly vulnerable to crisis, whether that's conflict, where around 60% of these deaths happen, or climate change, or also to recent financial cuts. And we salute WHO, UNICEF and UNFPA for co-leading this important initiative, the Every Woman, Every Newborn, Everywhere, a marriage of previous Every Newborn Action Plan and the Ending Preventable Maternal Deaths. Encourage all of you to look at the new website and join this. And all of us to think about this important topic, not just today, but what we can do over the next year and in the years to come for healthy beginnings and hopeful futures. Very important campaign launched today on a great webinar chaired by Femi Oki and with Tedros and many others speaking. Please do join and amplify. And on this webinar, we're particularly focusing in on newborns. So there is good news. There are many countries across Southeast Asia, the Americas and Europe that have met the target for reaching a neonatal mortality rate of 12 per 1,000 live births. It is doable. There are fast progressing countries. For example, China continues to be the fastest in the world, progressing at 8.8% per year. But there is also bad news. So the newborn deaths are stuck at 2.3 million per year since 2020. And this is particularly because of lack of progress across Africa, with continuing high births and also not fast enough change for mortality. So sub-Saharan Africa, at 15% of the world's population, almost half the neonatal deaths, 1.1 million per year, and a similar number for many decades. The rate of change is getting faster in South Asia, particularly where they're scaling up neonatal care, but it's slower in Africa and actually been slower since we entered the SDG era. So we want to focus in on where we can find hope. There are countries that are close to being on track, for example, Malawi. We're going to be hearing in more detail from wonderful leaders from Malawi, and we want to find ways to learn and go faster together to seize on what works and to make that happen. Because most of these newborns are actually dying in health facilities. There are, of course, areas across Africa where we still have high rates of home birth. But across facilities, both women and babies are dying for lack of quality care. And that is the place where we can and must go faster together in the years ahead. So on this webinar, we want to introduce you to an alliance that is helping us to go faster for newborns across Africa. And we'll be hearing about that in a second. We want to look at Malawi as the fastest progressing across Africa. And then we're going to have a really exciting comments from the Malawi Chief of Health Services. We're so honored to have Dr. Chunda with us. And then we will have a discussion panel. And all the way through, we want to be taking your questions. So please post that in the Q&A. Share with us your thoughts, your questions, your suggestions, and let's find ways to go faster together. So our first speaker today is the amazing Professor William Macharia. He sits in Nairobi, joining us live from there in the Aga Khan University. He's the deputy co-chair of the NEST360 Alliance that he will be telling you about. He's a pediatrician, clinical researcher, and also, I have to tell you, he's a world-beating plank competitor. He can do a plank off and beat even people who have never been beaten before. So over to you, William, to tell us about the NEST360 Alliance. Thank you.
Thank you very much, Joy, and welcome everyone. That's a really worrying statistics, but we feel that we are up to the task, and if we work together, nothing is unsurmountable. We can actually meet those targets. My task is actually very simple: to tell you what, who NEST is, what NEST does, how it does it, why it does it, and whether it has had an impact at all since it came to be back in 2019. So we are an alliance of about 23 organizations, most of these in Africa. We are in 5 African countries. These 5 African countries, like some of you may know, contribute nearly 50% of neonatal deaths in Africa. So very significant it is. We use multidisciplinary teams to do our implementations, which comprise of clinicians, biomeds, public health specialists, quality improvement specialists, and we also undertake evaluation and economic evaluation of our programs using experts that we have within the team. And what does NEST do? We enable governments and healthcare workers to provide life-saving care to small vulnerable newborns, and we use very basic strategies. One of providing technologies, where they are not available, and this is in most parts of Africa, as most of you must be aware. We also take into consideration that things cannot work piecemeal to save lives of newborns, so we have to institute a holistic approach that addresses all different aspects of the healthcare systems, from infrastructure going to leadership and all the other different areas. We also provide hands-on education that's followed up with mentorship. And we also believe in using data, which is collected live within the facilities to drive action. We appreciate the funding that we get from Gates Foundation, Elma Philanthropies, and SIV, because without them, we cannot make the journey that we are making now. Next slide, please. We also work, as with a team of, not only clinicians but researchers whose professional development we also care about. So as you can see from our the publications, which can be accessed through this QR code, we have a broad combination of authors, both from Africa and outside Africa. And the figures stand out for themselves down there for you to see. A good number of these publications are actually first authored by people from the South. We also share the products that we have in the implementation toolkit freely, and this can be accessed also through the QR code, which is shown there on our web page. Next slide, please. Where does NEST operate? We are in 5 countries, as I alluded to. And within these 5 countries, we cover about 144 hospitals. As you know, most the care for the small vulnerable newborns is delivered within health facilities, not at the community level. So that's where NEST actually concentrates within those facilities to implement the packages of care that I have outlined. We also avail data which at individual level so that we can be able to drive quality improvement. We have data which can also be used for which provide data which includes like health systems information or nurse ratios, electric power, downtime of electricity in the facilities, the coverage of the different packages of care, and we know which the main drivers are, like kangaroo mother care, the CPAPs, and things like hypothermia. So this information is available to the facilities live within the dashboard that NEST runs. We also assess the impact of what we do and its cost effectiveness through rigorous research. And I'm excited, particularly, to know that the next speaker will be quickly taking you through our achievement in reduction of significant mortality reduction in Kenya and in Malawi. Thank you.
Thank you so much, Professor William. Really fantastic. And you can tell Kenya is good at speed, right? Thank you for so much information and in such a short time. So we're now going to pass from the whole of Africa to what NEST is doing across 5 countries to zoom in on Malawi, the warm heart of Africa. And to take us through Malawi's story, over the last decades for newborn survival, we have none other than Dr. Umsandani Chumi. She's the newborn technical lead, the chief pediatrician in the Ministry of Health, Reproductive Health Department. She's the lead for Beginnings Fund in Malawi and also the NEST360 lead and part of the NEOTRI team. And what you may not know about Umsandani is she's also a very beautiful singer, but I don't think she's going to sing for us today. I think she's going to talk us through the important changes for Malawi and understand why they are running the fastest in Africa. Over to you, Umsandani.
Thank you very much, Prof. Joy. And I'm here to share this wonderful story for Malawi and how we've made progress, which we're very, very proud of and are looking forward to the future ahead of us. The neonatal mortality rate in Malawi is dropping really gradually, but at a rate that is faster than any other country in sub-Saharan Africa. When you look at the data from 1990 to 2023, at a 3% change rate, which is double any African country. And right now we're sitting with the UN estimates at 18. Our previous demographic health survey, in which data collection was in 2020, said it was 24, but 18 is a good place to be at. When our target is 12, we really feel that we can get to the target, although not quite yet on target, but we might be able to reach that target. We are pushing hard to get to that target, so we need to go faster. Next. So we applied the mortality transition framework that WHO and other team members developed to this curve on the newborn mortality reduction in Malawi. And you can see that we were in phase 1 a while back, and then in phase 2, but now really sitting in phase 3, really pushing ahead for us to be able to hit the SDG as planned. Next. But exactly what are we doing for us to be able to get there? Okay, so in phase 1, this was the pre-MDG era, where the real focus globally was child survival, primary healthcare setting, family planning, and immunization. And then in phase 2 was when we focused on maternal survival in the 1990s and child survival, with some activities around maternal care and beginning to shift from home births to more of facility deliveries. But now we're sitting in phase 3, where we are at 18, wanting to reach 12, where we are looking at what is happening in the maternal space. Now that we've got the women with us in the facilities, how can we make sure that the quality is good, the quality of their care is good for us to get a better baby? But also, we are beginning to increase the number of neonatal units in our districts, and we are operating in Malawi in a hub and spoke model, where we have central hospitals acting as centers of excellence with capacity that is stronger than the district hospitals, and to be able to share information with the district hospitals and any learnings, and to pull together to improve care. So now nationally, we have been able to hit the ENAP awareness target with making sure that every district has a neonatal unit and operating, as I said, in a hub and spoke model. So at least we've managed to surpass the target to about 97% when the target was 80%. So really, really an exciting learning from us here in Malawi, that these hubs, the central hospitals, are acting as centers of excellence. In each and every hospital that we've gone to in Malawi, we've really managed to be able to give 15 devices approximately to manage the newborn, and then give a supportive environment using clinicians and biomedical engineers. But also we are really strengthening the human resource capacity by making sure that we're having more and more increased number of nurses in to take care of newborn, from a place where we completely didn't have nurses, or maybe had 1 or 2, to a place where we're having 13 to 20 nurses in the neonatal units. And really this pragmatic approach towards being, thinking about our infrastructure. Yes, the baby is a small baby, but the space that they need and the devices to support them require space. So we're really embarking on this journey to strengthen the infrastructure in Malawi. Just to mention that we are very, very proud to be able to implement a newborn data set with very minimal variables, meaning that it's much easier to collect but meaningful data. And that this is done by the Ministry of Health data clerks, which I think we are very, very proud of. And this data set is now on the DHS2 server. We are able to see live dashboards with this data set. And we are also able to use this data nationally and at ward level. We get over 30,000 logins at the moment, where we are able to review our coverage targets, including CPAP and KMC. I think seeing district team leaders and members be able to access and use their data to improve care is a milestone that cannot be left without mentioning. But the news flash this afternoon is not just that we can do things. I think any country can do things, but that to do things and get some impact, I think that is the story that we're trying to really share this afternoon. Malawi is managing to reduce neonatal mortality, significant reduction statistically of 16%. And this is not of a small piece of data. It is of a robust data system of 36 facilities with over 200,000 admissions, starting from January 2024 up to about mid 2021, 2022. 13 of these facilities have made significant reduction of between 14 to 50%. Can you imagine a 50% reduction of neonatal mortality rate in a facility? And one of these is one of the largest facilities in Malawi. We are very proud of that achievement. Yet, of course, it's not without challenges. 4 of our smaller facilities have shown an increase in mortality, but we've prioritized actions to help them move forward and be able to hopefully also begin to see a reduction there. But all the facilities with significant mortality reduction have higher coverage change in most indicators, but especially CPAP and KMC. So really, making the story for CPAP that it will improve quality of care. And so coverage is key for impact, especially getting good coverage of CPAP and KMC and other interventions within this African continent will change the story of the newborn in Africa. Next. So the key learnings, if you didn't hear anything from what I said, I think there are 3 of them. Number 1 is that we need to invest in newborn care with government leadership for sustainability. So Malawi is government-led with multiple partner inputs indeed, including NEST360, Neotri, and many others that are on the plan. But we've got one plan as a country, and this is linked to the global plan, the ENAP or EWENE. Yet multiple partners are there. There's key coordination that is happening through the RHD, and we are really now beginning to strongly use the families and the parents to also advocate in this space much more. Secondly, we need to implement at scale using focused packaging for all. For example, we've been now able to produce a neonatal package that has, we've been able to put in a district hospital, and not in just one unit, but in more than 80% of our districts. In fact, 97%. So really, an investment is important for us. Even though we are in a space where we're experiencing these funding cuts, we just cannot turn away from the newborn. We still need to commit human resources and infrastructure to improve the outcomes of these babies. Finally, the quality of care is so critical. So it's not good enough to get coverage. We need both coverage, which is getting at scale, and good quality care. So we've been able to measure and close the gaps of the CPAP and KMC and other indicators like hypothermia and infection outbreaks by using our data and bringing the quality improvement initiative to strengthen our decision-making processes and to be able to mobilize our resources better and utilize and to get the good quality that we're looking for. So indeed, a systems approach with a lot of collaboration, in interdisciplinary collaboration. And so that's what's worked for Malawi, and we hope it works elsewhere too. Thank you very much for listening, and please don't hesitate to put your questions in the question and answer section. Thank you.
Thank you, Sandeni. That was a tour de force. Just so much hope from what Malawi has been able to do. Congratulations, and really look forward to hearing from your boss. So Dr. Lillian Chunda, who is the Chief of Health Services for Malawi Ministry of Health. We're so honored to have you here. Lovely to have the partnership with an adult physician. Congratulations on your many awards, including I saw also a Presidential COVID Award for Best Physician, and really important and impressive. And we want to pass to you, saluting what has been achieved in Malawi, for your additional comments and thoughts, and maybe a clarion call to all of us across Africa on how we can go faster together. So over to you, Dr. Chunda.
Prof, thank you for giving me this opportunity to speak to this gathering. And thank you, Sandeni, for a nice, elaborate presentation that you've made on behalf of Malawi. You have done us proud. On behalf of the Ministry of Health of Malawi, allow me to join the gathering to celebrate the tremendous progress Malawi is making in reducing newborn death. You all know that reduction in newborn death was thought to be impossible, especially in this part of Africa. And seeing Malawi demonstrate such progress brings us much joy and pride. These achievements have been attributed to various interventions, as alluded to by my colleague, Dr. Sandeni, through government and also our stakeholders like NEST360, for us to improve the quality of care for the newborns in Malawi. And as government of Malawi, we are so grateful for the support that has been rendered so far. While we celebrate this wonderful progress as a country, we are also cognizant of the fact that we also need to increase the existing efforts so that at least we achieve the SDGs by 2030. So as already highlighted by Sandeni, the ministry at the moment is recruiting additional health workers with the aim of increasing the number of our workforce, more to say the nurses in the facilities. And we think that this will ensure that the newborn ward will be able to get its own share in terms of HR. We also want to continue supporting the biomedical engineers and other ancillary healthcare cadres that are critical to the newborn care. At the same time, the ministry is also working to strengthen the supply chain for both maternal and newborn equipment, medicines, and supplies. I think in the past, everything was bundled up together as an essential medicines list. But now we've known that I think the list might need to be ring-fenced to tackle specific at-risk groups like the maternal and the newborn as well. And that's why now we're talking of maternal bundle as well as newborn care bundle. Also, let me highlight the implementing quality improvement that is driving the uptake of the interventions that we have so far in the country. QI cannot be done without data. And when I went to one of the districts in Malawi, I was impressed with what I saw, that even at that level, there was the data and the dashboard at the lowest level being applied by the lowest cadre in our healthcare system. And I think this is what we need to promote and probably share amongst all the African countries, that without proper data systems, then obviously we might not be able to provide quality care to our populations. And what we've seen as Malawi is the improved data systems so far, and the QI, it has driven the recent mortality shift amongst the neonates. Our major challenge as government, we are aware that we have inadequate infrastructure. I think historically our maternity wings, the way they were constructed, I think they didn't factor in the neonate section. And as such, as we're transiting all this, we are making makeshift rooms as neonatal wards. And we believe that such rooms will be able to provide tentatively the care to our vulnerable babies. And at the same time, through government as well as through our partners, we want to make sure that all hospitals, even at the lowest level in the rural areas, they have at least adequate infrastructure, either by constructing or probably also changing or extending some existing wards, so that at least we can be able to cater for our newborn babies. The other challenge which we've experienced as a country, and I think which still remains as a challenge, is the delays in referral systems for both maternity as well as the small and sick newborns. We are glad to share with this gathering that we'll be joining our Tanzanian team who have benefited from the M-Mama transport system. And we'll begin the implementation of the transport system mid this year. And we hope that this will be able to tackle the issue of delayed interfacility transfers for both pregnant women as well as the babies. I'm sure that this global community here is listening, that Malawi government is committed to support the newborn care efforts. And that's why at the ministry level, we thought that we need to bring in some technical expertise like Dr. Msandeni, so that at least they should be able to guide the government. My sincere gratitude goes to all the partners that are supporting the government of Malawi. We don't take that for granted and we really appreciate. And as I close, let me call upon all African countries to hold hands in fighting for these vulnerable babies. We believe and we know that it is possible to reduce newborn death. Thank you very much for listening. Thank you.
Dr. Chundna, thank you so much. Really, zikomo kwambili. And Malawi has the warm heart of Africa, is sharing your learning. And just listening to you, it's very clear the thoughtful implementation details on all the different components of the system, but also ensuring that every woman and every newborn everywhere in Malawi gets the core package. So thinking about the transport system and the other aspects too. So thank you for all that you're doing. And thank you too for being willing to share your learning across Africa so that we can go faster together. So we now move forward from looking at Africa as a whole, looking at how NEST can contribute, looking at Malawi in detail, to hear richness back again across the continent from a fantastic panel. I'm very honored and excited to welcome these beautiful people that you can see in front of you. And we're going to start with Professor Chinyere Eziaka, speaking from Nigeria, the giant of Africa, and also speaking from her newborn ward where she's been working today. So Chinyere is a neonatologist. She's a founding member of the NISOM, the Nigeria Neonatal Medicine Society. She's led, even I remember maybe 15 years ago, Chinyere was at the first newborn situation analysis in Nigeria. And now is the lead for NEST in Malawi, NEST360 since 2019. So Chinyere, as you stand in your newborn ward and as you look across Nigeria as the giant of Africa, I know that you feel on your shoulders the weight of 250,000 newborns dying each year in Nigeria. That Nigeria needs to run maybe 10 times faster to reach the target 5 years from now for newborn survival. And if you look at what you have learned and what you see, what do you think are the ways that NEST360 can help the Nigeria government to go faster together in partnership? Over to you.
Well, thank you so much. Thank you so much, Joy. And good afternoon and good morning, everyone. And I must join the world to say congratulations, everyone, on this great opportunity of the World Health Day with the focus on the vulnerable newborns. And looking at learnings from the NEST360 program, I'm glad to say that since inception in Nigeria, in 2019. The program has been mostly government-led and government-owned, and this we're quite appreciative. And looking at the current climate, there is presently more prioritization of the small and sick newborn, which is really the focus that NEST360 has brought to the table. Because these are the key group, these newborns that are dying in large numbers, contributing 80% of mortality within the neonatal age group. That the country has articulated and galvanized efforts that we now have national guidelines on comprehensive newborn care for every baby that's delivered in the secondary health facility and in the tertiary health facility, having training programs, training of trainers, and this has gone into cascades into the states. There's been, with the NEST360 program, since inception in 2019, there's been more focus on capacity building within the neonatal space, to training of not just the clinicians, the doctors, the nurses, but integrating the biomedical engineers as key members of the workforce. And these are crucial. And moving forward within the capacity building space, we've also seen the need to have more trained neonatal nurses and to have them. And with this, working again with government and the Nursing and Neonatal Council, the Nursing Council of Nigeria, we've been able to commence the neonatal nursing program. This is still in process and within the second year. And this is crucial because you need the right people, you need the right equipment for us to save these babies that are dying in large numbers, for us to make the mark in neonatal survival. Another key area that is critically important to accelerate neonatal survival as we are speaking today is the need to have those devices, the low-cost equipment, both for diagnosis, both for monitoring, both for treatment. For instance, we've heard Malawi at Sandeni speaking about CPAP machines for respiratory support, oxygen therapy, phototherapy, the babies that need feeding, the efficient pumps, etc. Without this, we'll have continuous mortality ongoing. So there's a need to have all these key ingredients and to have it harmonized in a framework for better supply chain and distribution. Then data is key for quality change. So we're looking at the right people, we're looking at the right time, because it has to be prompt with the correct referral system, the right devices and the right data to drive that change. And this is all NEST360 has brought to drive change in Nigeria. And this is key, working with both the national and subnational government. But today we're saying that for us to expedite, we need to go faster. There's need for all these very novel interventions, not just to be at pilot sites, but to be cascaded to all states within the country so that there'll be more impact. And furthermore, looking at the current coverage data results from the interim analysis, it has shown that there is mortality change is dropping in the 9 NEST360 facilities in Nigeria. And this is remarkable. And also, wider scale-up is ongoing to include more states. However, one key gap is that impact is needed where most births are in facilities. We still have the urgent need to improve more facility births, because in certain parts of the country in Nigeria, there's still more home births. So there's a need for us to synergize, to work harder and bring more mothers to deliver in the facilities so that they can benefit from these very crucial life-saving interventions. We have to integrate community-based maternal and neonatal care interventions, reduce home births, emphasize on family planning, because it's all crucial. There has to be linkage between neonatal and maternal. And it's also very, very important to have our national health insurance package for mothers and babies improved so that it will reach every mother in the remotest area where they are. Currently, the out-of-pocket expenditure for patients is actually taking a lot of mothers out of the facilities to deliver. And this has to be improved on. Then another area is partnership and collaborations are many in Nigeria, and this we're very, very grateful to all our partners working with the Federal Ministry of Health. But the coordination need to be looked into such that these programs are not just in certain areas of the country, it needs to cascade so that it will get to all the areas, because babies are dying in many other states of the country. So, and this lesson we can take from the wonderful presentation that Malawi has put across on multi-partner coordination. So there is need to have that so that every ward, every local government area, every state in the country, all the children are benefiting from partner interventions. So, but also to actualize all this very lofty, wonderful programmed interventions, for us to move faster, for us to change the needle, for us to drive change, we need funding. Money is crucial. Investment case is very, very important. And learning from Tanzania's investment case, there's need for coordinated implementation plan. We need to have a costed plan that will include both the floor plans, both the medicines, both the devices, the human resources. We have to bring all to the table. Nigeria currently has the Every Newborn Action Plan, the NINAP, costing it, having a roadmap so that the strategy can be seamlessly implemented. That is key. And linking all this to maternity and then including an effective framework for referral and transportation services across the continuum of care is very, very important. Once again, thanks everyone for this opportunity, and to say again, happy World Health Day to everyone, with the focus on the small and sick newborns. Thank you. Over.
Thank you so much, Chinyere, and so important for the giant of Africa that we have a champion who is full of passion and clarity on what to do. Yes, absolutely, we need to do better in hospitals, but also very important points about the out-of-pocket expenditure and also places where facility birth coverage is lower. Thank you for what you are doing, and we stand with you. So we're going to move from the giant of Africa to a giant of biomedical engineering. So Professor Rebecca Richards-Corsham, she is a leading biomedical engineer with actually, I think, at least 17 patents to her name. She has worked both on cancer innovation and also on devices for maternal and newborn care. She's our leader in NEST, and she also has an incredible record of probably even more marathons completed than her patents. So Rebecca, I'd like to ask you, as a person who's really thought as an engineer about systems change, how do you think that the learning on systems change across NEST can help us to go faster across many African countries together? Over to you, Rebecca.
Thank you so much for the question, Joy. And it's really a pleasure to be here with so many of my colleagues from NEST. I think that engineers can bring three important things to solving this challenge of improving newborn survival. And the first is really to focus on what is the equipment that is needed for level 2 newborn care. How can we make sure that equipment that is affordable and effective and rugged is actually developed, that it's delivered, and that it's maintained? And as you know, in NEST, we worked really hard to do this. We've delivered over 6,000 different devices for newborn care. We've been able to maintain a 99% uptime for those devices. And by building capacity for biomedical engineering across all of the wards that are in the NEST program, we've maintained over 90% uptime for all of the equipment that is in the ward, regardless of whether it was new or whether it was already there on the ward. But I think maybe the second thing that engineers can bring is even more important, and that is a systems thinking perspective, we know that healthcare systems are really complicated. Newborn care, level 2 newborn care is a very complex system, and it requires a lot of different components. Engineers can bring a systems perspective to help simplify the system and think about what are the key points of intervention. And in NEST, we believe those are making sure that the infrastructure and equipment needed for quality level 2 newborn care are available, making sure that you have the human resources that are needed to deliver that care, whether that's high quality nursing care or care from pediatricians, or whether that is biomedical technicians who are taking care of equipment. And finally, making sure that everyone who is a part of that system has access to data. They can look up on their phone and see the nested dashboard to know how is a facility performing, where are there the most important places for improvement, how do we focus in, double down to make those improvements and monitor whether those efforts are making a difference. So the second point is really that systems level thinking. And finally, I think the third thing that engineers can bring is a very important focus on sustainability. In NEST, we believe it's really important not to have any parallel systems, to partner with governments and really all work together towards strengthening that one pathway to improving care so that when programs transition to full government ownership, any improvements can be sustained and built on to continue that improvement. And I think this approach can go beyond the neonatal ward. It can drive improvements in the operating theater, in the laboratory, in the intensive care unit. So I think it's a really exciting opportunity to build on what NEST has learned. Thank you so much.
Thank you, Rebecca. And so rich and important that systems changes, not just on the neonatal ward, it goes above that level, that we need to not be overwhelmed by the complexity, but find ways to develop and deliver and to sustain. I've just learned so much from you, not just now, but over the past years, and thank you again. So we're going to move into a double A billing. We're going to go to Abby and then to Anne, and then we will come to the wonderful Miriam. So Abby, just so excited to have you here as a leader for implementation research across Ethiopia over the last 15 years, important work on simplified antibiotics for newborns at community level, antenatal corticosteroids, KMC learning, and now the lovely marriage of Saving Little Lives and NEST 360 to have SLL 360. We're so happy already to have been learning together with you over the last year since this new marriage started. And we would love to hear from you as someone who has joined this kind of systems thinking approach. What stands out for you that will help you to go faster in Ethiopia and maybe could help other countries as well? So over to you for your thoughts on key learning so far and what next.
Yeah, thank you, Joy. Can you hear me okay?
Yes, very well, thank you.
Yes, so I have cold, so I'll try not to cough in the next 5 minutes. So we are very pleased to join the NEST360 Alliance, and we have already learned a lot from the program as demonstrated by the impact in Malawi. So I think the key learning is that we have adopted in Ethiopia in trying to scale up in the Saving Little Lives facilities across 226 facilities in Ethiopia, starting with the 16 that we are working on today. One is an individual inpatient data system. So as we have seen from Malawi, there is, the data is very powerful in driving change, monitoring impact, and also empowering healthcare providers to make a decision that guides the clinical care. So we are very pleased to even extend the data system to maternal side as integrated maternal and neonatal inpatient data system, which will be which is being built in the Ministry of Health data system, the DHIS2 tracker. And we are also very pleased to learn from the NEST360 program the power of identifying, installing, and maintaining devices that Rebecca has beautifully presented. So devices, provision of devices to facilities is not adequate. The healthcare providers and biomedical engineers, both at facility and national, regional levels, need to be empowered to make sure they can use the existing devices and also, strengthen the biomedical system overall. And the other key learning is, use of data, individual inpatient data, to drive quality. So we have a relatively good quality improvement system and structure in Ethiopia. We want to push that experience and culture into the maternal and neonatal system to again improve the care that this vulnerable population require. And the other is education, which is about building the capability of frontline clinicians, both at maternal and neonatal side, and also biomedical engineers, data managers, and data clerks, and quality improvement teams. So we are also integrating in the existing government system, the learnings that we have gained from NEST. And also infrastructure improvement. We also believe from our experience here in Ethiopia, IKMC will be a strong foundation to connect the maternal neonatal care and also improve the agency and neurocognitive outcomes, the agency of parents and mothers, and also neurocognitive outcomes of neonates beyond mere survival of the newborn. So we are very proud and happy to work with the Alliance, and also to be part of this global movement. We don't have much time, but I think this is an opportune time for the neonatal global community to move faster together. Thank you so much.
Thank you, Abby. And Ethiopia is famous for your runners. Thank you for the running that you're doing for Ethiopia, and especially for bringing in kangaroo mother care as transformative for the way we do care, and really truly putting the woman and the family at the center with their baby. So important, and so much learning from the depth of what you and Fitsum and many of the team are doing on that. Thank you. So we're going to move from the runners of Ethiopia to Anne Magegi, who is really a heroine and thought leader for maternal and newborn health. She's been based in the past in South Africa, where she really stood up for equity and integration of maternal and newborn health. She's been with Alma Philanthropies now since 2010, and most recently in New York has the lead for health for Alma Philanthropies, where she's been a thought leader in the setup of the Beginnings Fund. So, Anne, could we ask you your thoughts on how the Beginnings Fund maybe can help, particularly on this need for hope and progress for newborn survival, despite challenges that we see in the world around us at the moment? Over to you, Anne, and thank you for joining us despite your plane mishaps. We really appreciate it.
Thank you, Joy, and very nice to be here with everyone. Really glad to be part of this community. So just quickly, the Beginnings Fund is a new philanthropic collaborative. You won't find it yet if you Google it. We are not yet officially launched, but will be launched hopefully by the end of this month. And the purpose of this philanthropic collaborative is to help accelerate reductions in maternal mortality, newborn mortality, and prevent stillbirths. Doing this in partnership with African governments. We're looking at 9 countries to start, but with the ambition and the goal to keep going. And Malawi is proudly the first country that we are supporting with investments. And we have definitely learned from NEST, and NEST has informed all of our thinking to date, and many of the same donors are part of Beginnings Fund. And what we really are holding dear is to put the mother and baby together in our thinking and not separate them. We know that many of the countries that we're looking at have sort of made the transition to most or the vast majority of women giving birth in health facilities, but we need to really look at the quality of care. So Beginnings Fund will be making investments across 3 pillars, being the commodities and the equipment that health workers need to have at their disposal, and exactly the newborn bundle that NEST has been so exemplary in helping define and helping deliver, as well as looking at the health workforce, not just in terms of in-service training, which is very important, and clinical mentoring, but also looking at additional health workforce. Some countries actually have unemployed health workers who could be added back into the system with government absorbing them with a bit of outside funding. And that's happening quite well in some countries. And then also upgrading the health workforce. We need neonatal nurses. We need neonatal nurse faculty to teach neonatal nurses. Also, the whole gamut. If you take a country like Malawi, I think with over 650,000 births, currently in the public sector, there are less than 100 pediatricians, obstetricians, and anesthesiologists. And those are the specialists cadres, but we also need the anesthetist clinical officers, the anesthetist nurses, the theater nurses. And so we're really looking at supporting countries to upgrade existing health workers, but also looking at pre-service education and competency-based education as well. And I would say our approach is very practical. It's very nuts and bolts. Besides the workforce, we also want to look at the system enablers. Dr. Chunda spoke to Mama coming on board in Malawi, and we'll be helping support that, and are looking to do a bigger partnership with Mama in other countries as well. But very importantly, the data. We now, thanks to NEST, have very good newborn data. We need similar data on the maternal side as well. And then very importantly, and not least, is infrastructure. I think it was Queen Dube who said, we built small rooms for small babies, but we really have an opportunity now for countries that haven't yet pushed newborn care, and even those who have, down to district level, to build and renovate health facilities to keep the mother and baby together, both in the labor ward for IKMC, and then of course, mother-baby neonatal units. And real opportunities to improve care and also improve space for health workers providing that care. So in a nutshell, that's what we'll be working on. Very excited to be in partnership with Dr. Chunda and Dr. Chiume in Malawi. They're leading this effort. We are coming alongside with some investment and really welcome other donors to join us, both through the Beginnings Fund or alongside. And we hope to get a few other countries started this year, including Tanzania, Rwanda from an investment point of view from Beginnings Fund, as well as Ethiopia and Kenya. So those are our plans, and very happy to share them with you today. Thank you.
Thank you, Anne. So important. And, you know, the theme for World Health Day today is healthy beginnings, and also hopeful futures. And at a point when many, previous funders are stepping back, we want to salute you and Elma and your funders who are working with you to do this, because mothers and newborns are particularly vulnerable to all these crises. And thank you also for including the stillbirths and for underlining integration and government leadership. Thank you so much. So you said that Malawi was the first off the blocks, and Malawi, as we have seen, is the fastest moving for newborn survival. We're now going to leap to the country you mentioned next for starting with beginnings, beginning with beginnings, and the lovely Dr. Mariam Johari. So Mariam is a medical doctor. She has her MPH with distinction from Nottingham. I did my medical degree in Nottingham, so the fellow Nottingham person, nice to meet, nice to have that additional piece of information about you. She's worked closely with the government of Tanzania previously for GTZ, so German aid. And she's been our country lead in NEST since last year. So Mariam, looking at Tanzania, how do you think the NEST can walk with the government to go, or run with the government to help go faster for newborn survival across the country? We know you have one of two female presidents who's very committed on this. There's very a really impressive commitment from the top and all through the government. What can be done to help that translate into reality? Over to you.
Thank you so much, Joy. So as you rightfully said, I think under the leadership of our president, Samia Suluhu Hassan, the government has really demonstrated a strong commitment to improving newborn health. And NEST360, we are really honored to sort of journey alongside the Ministry of Health in this effort, not just as a partner, but really committed as an ally on the ground. And so what we focus on is really the implementation practicalities and shared learnings, really with a strong focus looking at ensuring the right spaces, the right people, and the right data are in place to deliver quality newborn care. And I think Prof. Chinere really put it and said it well and put it bold, starting with we need the money. And so NEST360 in Tanzania, we're honored to work with the Ministry of Health to cost its national scale-up plan, which has led to an investment to date of around 30 million towards improving small and sick newborn care. Looking at the right spaces, we've also worked together with the ministry to develop and disseminate standardized floor plans for neonatal care across the country. These floor plans are really designed to ensure that all newborn units meet the standard required to provide high quality care. And this is what we are using as we enter phase 2 of the program, really working alongside the Ministry of Health to upgrade infrastructure at district level national neonatal care units. So really ensuring that units are consistent and that the quality provided is unified across all facilities. Looking at the area of having a skilled and sustainable workforce, and I think Anne alluded to this as well. So we're really passionate and looking at strengthening both pre-service and in-service training. So at a pre-service level, we have worked together with partners such as MUHAS, as well as other newborn care partners, to work together with the Tanzania Commission of Universities to establish an MSc in neonatal nursing as well as pediatric nursing. And this is expected to launch later this year. In parallel to that, also looking at pre-service training, we've supported the ministry in establishing 15 technical and clinical skills lab across the country to really help support that competency-based training for both nursing and biomedical engineering students. Of course, making sure that we do not leave our biomedics behind. And not really just stopping there, but ensuring that we have trained trainers of trainers to sort of continue that continuum of training. For the existing workforce, we support integrated in-service training models with a strong emphasis on mentorship to ensure that the current healthcare providers are equipped to really deliver high-quality care for small and sick newborns. We know and understand, and I think this has been talked about across, since the beginning of the presentation, as well as all the panelists. We know that data is the foundation for everything. And so the program in Tanzania is really advocating for the integration of the neonatal inpatient data set into national health data system. As Professor Rebecca mentioned, we're not here to sort of create parallel systems, rather build on existing systems. So really ensuring that newborn data is captured and used for decision making. We've also supported the government in developing and recently launching a newborn national newborn register. And in our NEST supported facilities, of course, the healthcare workers have access to real-time dashboard that is also accessible via their mobile phones of newborn care data in their respective facilities, really enabling them to use this data for quality improvement at their facilities. And of course, we don't underestimate the power of partnerships. We have great partnerships throughout. Particularly one we'd like to highlight is looking at sort of the continuum of care from the maternal side, but into the neonatal side, a partnership with Touch Health. So really working with partners to collectively move faster together. And I think like Malawi, we're really committed to doing everything in partnership with the government, and NEST360 can really help Tanzania move faster together. Thank you.
Asante, thank you so much, Mariam, and all the team in Tanzania. And we salute also your really strong government ambition. Putting in money, following it through with wanting to implement, these 100 new units, and then thinking about the key gaps as well as the infrastructure, also the neonatal nurses who are so critical for change. So thank you for what you are doing. And we also want to thank Dr. Lillian Chunda, who's about to have to go. I think she may have gone already because she's meeting the minister. If you're still here, Dr. Chunda, are you able just to give us a word of encouragement, and particularly about the question on partnership? If you could just quickly address that before you have to go, that would be super appreciated. I think she may have had to go already. She has a meeting with the minister on that hour. So we have a number of questions that have been asked. One of them is particularly around which interventions make the biggest difference. So maybe I'd like to pass that to Chinyere, if that's possible, please. So the question is, amongst the interventions that are part of the small and sick newborn care, which ones do we think are having the most impact? And can we do them alone, or do they need to come together with others? Chinyere, are you able to unmute and take that question for us? Oh, maybe having problems with your internet. Could I maybe ask Mariam to take that then? I know you've just been speaking, but could we pass that back to you? Because I know you've been looking at this in Tanzania.
Yes, absolutely. So definitely I would say CPAP plus another additional intervention. I think looking at the data across the NEST360 countries, we've really seen what quality timely CPAP, what effect it can have in neonatal mortality, that combined with another intervention, for example, KMC, for the premature babies, can really have significant impact on neonatal mortality.
Thank you. Yes, and in the interim analysis, which is the data that Sandy was presenting from Malawi, looking at mortality, which we will publish in more detail this time next year when we have completed the time period set out by protocol. What we have seen is CPAP, KMC, and then also babies being cold on admission. So in Malawi, 2/3 of babies were cold on admission, and that has been happening in the cold season each year. And this year, Malawi is really moving forward on that now. We also know that infections, hospital-acquired infections, are a risk. Rebecca, would you like to add something to this?
Yeah, I totally agree with what Miriam said and what you have said. I think there's maybe two enabling things that really are important behind CPAP and hypothermia and KMC and infection. Those are data. And I think, we've heard so many of the panelists and speakers today talk about the importance of everyone having visibility into the data. I think that's so important. And the second one is, I think, access to commodities and supplies that are needed to be able to do good CPAP, to prevent infection, to diagnose and treat infection, and really, really partnering with government supply chains to be sure that there is a steady supply and ready access to commodities and supplies, I think are two big factors in getting to improvement and sustaining improvement.
Thank you. So important. And I think that answers the first question that was in the chat. What are the strategies that are enabling that quality of care? What are the inputs? So important. What we'd like to do now, I think, is to quickly go through the panel. And if you could each give of the many things that are possible, what you think the one thing is that can help us to really get up a faster speed for newborn survival across Africa. So I'm going to start with Abby, as the long distance runner in Ethiopia. What's the one thing you think will make the biggest difference going forward?
So it is difficult, Joy, to pick one thing, but if we should, I think, newborn health program globally is very, very much underfunded. So we need both from domestic and international community adequate funding to support the program.
That's really important. And there was a blog we just put out this week, re-looking at donor funding, and we reflected a year ago that USAID was half of donor funding mentioning newborns, so even more vulnerable now and more important. So very critical. Chinyere, I don't know if you're able to give us your one thing from the giant of Africa to go faster. I don't know if your microphone is working now.
Yes, thank you so much, and great apologies for the glitch in the internet connectivity earlier. Yes, to sum it up, we all know where the gaps are, looking at human resource, looking at the devices, looking at the data, looking at country ownership. So I must say that if countries own it, we have the ideology, the mission and vision is taken up by countries, owned by countries, led by countries. In that way, we're able to not just be running pilots in few facilities, because the babies keep dying in large numbers. but the need to scale this across, because we know where the problems are, we know what the solutions are, is need to have that investment and then cascade it so that it will reach every baby in the spirit of the Every Newborn Action Plan. We're racing for SDG 3.2, and every baby needs to have that great intervention. Thank you so much, and it's been great speaking with the panel. Thank you.
Thank you, Chinyere, for that. Every woman, every newborn, everywhere. And Nigeria also has the capacity to step up on this. We look forward to seeing that. So I'm now going to move to Rebecca. Could you maybe share with us what you think the one thing is that would be transformative?
Yeah, thanks, Joy. You know, the one thing I think would be most transformative is committed partnerships. I think 2 months ago, we knew there weren't enough resources to solve this problem, and now there's even fewer resources. So how do we come together and work together to raise those resources, to use them as efficiently as we possibly can to continue to make progress and to increase the rate of progress? Thanks.
Thank you, Rebecca. So important to maintain hope and realism and to go faster together. Anne, I'm sure there are many things you could think of in beginnings. What do you think, if you're looking out across Africa, would be most transformative for change?
Big question, but one very simple answer that I'd started to help me think about it is just wherever we have a CMOC, we should have small sick newborn care. And NEST showed us in Malawi how we could do that, you know, very simply and at low cost in terms of the renovation side of it. Now they've sort of outgrown it with demand, but you can get started. Yes, we need investment in equipment and data and the human resources to go alongside. But I think just as planners and as we think and as advocates, wherever you can get a C-section, you should also be able to have your baby well cared for. And we can see the data out of Mama in Tanzania. That's where the newborns can't be served yet at most CMOC sites. So we need to do more to include the newborn at all of those places. Thanks.
I love that, making it a norm that if we have emergency obstetric care, we should also have the provision for the baby. And that will really be important and will come in the upcoming norms and standards that are coming from WHO and UNICEF soon. We have to make that a norm for health systems. Miriam, I'm going to pass to you again for the last word, and then we're going to move forward to close this webinar. From your angle in Tanzania, what do you think is the one thing that would be most transformative?
Thank you so much, Joy. And I think sort of summing everything up and bundling everything together, I think the one thing that is needed is commitment. So looking at commitment from funding, you know, we can easily get lost in the noise, but I think we really need to focus on the data. What is the data telling us? I think it's clear the interventions are working, you know, so really being committed to make that change.
Thank you, Mariam. And I think that commitment also takes leaders. So I want to speak together to all of us who are here. We still don't have enough leaders in this area. And this is a place where maybe also sometimes we're too nice. So as we go forward with commitment and leadership, how do we stand up, make the case for women and their babies across Africa, and make it in a way that is smarter? Yes, we have the ethical and the moral and the equity arguments, but also the return on investment. How can we do that together? And please do reach out and join this toolkit. We had actually 55,000 unique users last year, and building this community where we can go faster together. Don't start from scratch on tools. There are many education tools, actually 1,000 tools in 15 languages. So please do join us, go faster together. Please join this exciting webinar next week on climate. newborns and women who are pregnant, stillbirths, particularly vulnerable to climate risks. How do we mitigate that? What can we do? And very practical suggestions from the speakers next week, who are world leading experts on this. And then in May, we will have Kangaroo Mother Care Day. This is highlighted as a really critical part of transformative change. And very excited also this week to announce the birth of this partnership between ANA and NEST across Africa. So in these days, let's join together. Huge thank you to all our speakers. Really amazing learning from Malawi and across Africa. Thank you, William. Thank you, Sandy, who had to step off for an emergency. Thank you, Dr. Kunda. Thank you to all our panel. And please do join the campaign for World Health Day. And please do join us to go faster together for women and babies across Africa. Thank you all so much.